Okay, well, let's switch gears a little bit and turn to mantle cell. You mentioned that the label indication for acalabrutinib is in mantle cell. Can you tell us about the data that led to that approval?
Acalabrutinib has been studied as a single agent or in combination with rituximab. It's approved, to my knowledge, as a single agent in patients with mantle cell lymphoma. This is one of those areas where I think cross-trial comparisons is very difficult to do due to maybe subtle differences in prior lines of therapies, methodology of response assessment, but the drug appears to be active and well tolerated. A high proportion of patients having very, very impressive response rates, as well as PFS and OS.
And that's in the relapse refractory setting?
Relapse refractory.
So currently, excuse me, I'm an acute leukemia doc, but if I remember right, the treatment of mantle cell lymphoma can include high-dose Ara-C-based regimens like DHAP, hyper-CVAD,
consolidative transplants.
Right, and bendamustine rituximab.
Mm-hmm.
Do you think that there are patients that could benefit from BTK inhibition as first-line therapy? Are there patients who wouldn't tolerate those intensive chemotherapies?
Absolutely, and I think it's actually happening in clinical practice. I don't know the proportion, but I would say at least 5 to 10% of frontline treatments are targeted agents even now. There are high-risk patients. If you have a patient with a p53 mutation or a 17p deletion with mantle cell, they do equally poorly with chemotherapy as you would expect a CLL patient to do. The same also may be true for IGHV unmutated patients. They have prognostic significance in mantle cell as well. And there I do think that there's a role for a targeted agent, or if you have someone who's extreme elderly or multiple comorbidities where you really don't see them tolerating high-dose cytarabine and a transplant or multiple cycles of hyper-CVAD, there's a strong argument to be made for a targeted agent. And BTK inhibitors have certainly been studied. IMiDs have been studied. There's a New England Journal paper of R-squared as a first therapy for mantle cell lymphoma that looked to be active and well tolerated. So I think it is a shifting paradigm where we're going to see the proportion of patients treated with targeted agents for mantle cell will increase a lot in the next couple of years.
Would you recommend using a oral targeted therapy in more than just the infirm patients if they're eligible for chemo?
I think it's a hard question. Certainly if there's
That's why I asked it.
Yeah.
That's why you're here.
I think there's a rationale for doing it, certainly in research. I think for individual patients, it's a case-by-case basis. I think in order to avoid a standard of care with a lot of years of a long track record of what we could expect in terms of PFS, you'd have to have a biologically aggressive mantle cell such that you thought chemotherapy was more risk than potential benefit to patients. I think those patients definitely exist. High Ki67, high MIPI score patients, blastoid variant, p53 or 17p deleted. Those types of patients are ones you could argue where you may not want to expose them to something that you think is destined to have a very short PFS. But otherwise, I do think the standard of care still remains rituximab-containing, cytarabine-containing therapies and consolidation with autotransplant.
So like everything else we do in oncology, we have to decide when we see that patient, are we on a curative path? Are we on a path of just palliation and make the appropriate choices?
Well, I think in mantle cell, no matter what path you get on, you're still on a palliative path.
Really?
I don't think anyone is cured with even stem cell transplantation. It just improves the PFS dramatically over standard dose chemotherapy, but I don't think anyone is really arguing that cure is the endpoint of even dose-intensive therapies at this point.
Well, then clearly more to do. How about ibrutinib in mantle cell?
Same story, very active and approved in the relapse refractory setting, generally well tolerated. Of course, all BTK inhibitors, if you pick CLL as the bar, are a little bit more of a disappointment in mantle cell because the PFS is shorter in mantle cell lymphoma. So this is an area where combinations, for example, are potentially more exciting, or the addition of anti-CD20 antibodies could potentially be more exciting for these patients. But certainly ibrutinib in the relapse refractory setting is a go-to first therapy along with acalabrutinib when patients have been treated with standard of care, whatever you want to define that to be, as their first therapy.
Okay.
So very few patients, I think, are going from chemo to chemo at this point.